Bridging therapy is widely used to control the disease while patients with large B-cell lymphoma wait for CAR-T cell therapy. We also know that a good response to bridging therapy is associated with favorable survival outcomes. However, one question remains. Should you give more than one bridging therapy line if the patient fails to control the disease after one line of bridging therapy? So to answer this question, we conducted a large real-world study using the French DESCAR-T registry. We included 777 patients who had a large B-cell lymphoma. They had all received at least 2 prior lines of therapy, at least 1 line of bridging therapy, and they were all intended for axi-cel. And we compared patients who received 1 line of bridging therapy to those who received more than 1. So what are the main findings? So in the entire cohort, we can see that patients who received multiple bridging therapy lines have inferior OS and PFS than those who received only 1 bridging therapy line. Now, among patients with progressive disease after a first bridging therapy line, giving additional bridging therapy line only improved disease status in a minority of patients. And even if you reach a disease response with additional lines, it did not translate into favorable outcomes as seen in patients who achieve a response with only 1 bridging therapy line. Also, and importantly, persistent hematotoxicity was more frequent with additional bridging therapy line. And finally, with a propensity score weighted analysis, we show that in patients who are infused with CAR-T cell in progressive disease after 1 bridging therapy line, those patients have a better overall survival and progression-free survival than those who received additional bridging therapy line because of the failure of the first bridging therapy line. So overall, delaying CAR-T cell infusion to give additional bridging therapy lines did not benefit to the patient. There was no improvement in terms of survival, and it has increased the risk of hematotoxicity.